Hello, everybody. It's Jody Franklin here, and I am really delighted to have Dr. Siebecker with me here today. It's Dr. Allison Siebecker, and she is a naturopathic doctor, licensed acupuncturist as well, and she's been in this field for over 34 years and has also her master's in Oriental medicine. But just to give you a little background, she's going to talk today, first of all, about the essential concepts of SIBO and IMO, treatment and relapse and prevention and all the proven methods. But she has so much expertise in this field. I'm so excited to have her on. She was the co-founder and former medical director of the SIBO Center for Digestive Health at the National University of Natural Medicine Clinic, and is the 2021 Lifetime I don't know how to pronounce it,
Borborygmus
Award recipient. And she specialized in the treatment of SIBO since 2010. She's also an instructor of advanced gastroenterology at NUNM and is the IBS Board of Advisor and faculty for GI Health Foundation. So many credentials. She's the co-founder and curriculum coordinator of the 2014 to 2016 SIBO symposiums, and she teaches continuing education classes for physicians. In fact, the course that she does offer, and she's going to be offering a special deal for our group today, offers 20 CME credits. So if any of you are looking to fulfill your CMEs for the year, this is a great way to do it. And she's also offering our group today a special ebook, which is free, absolutely free for this group. It's called Check Your Blind Spots and Become a Better SIBO Practitioner. And Terry and Aaron are going to, in the comments on the Facebook and also in this group, you're going to get the link to that right now in this webinar in the chat. So if any of you are interested in that, it looks amazing, and I can't wait to get my copy. But Dr. Siebecker, thank you so much for joining us today.
Thank you so much for having me. I am thrilled to be here, Jody. Thank you.
Yes, absolutely. And I know there are so many questions, which I'm going to pepper some in the end. But if you want to go ahead and just present what you had to do today, I know so many people are interested in this topic. I know that if all the functional medicine practitioners, any kind of practitioner out there, coaches, whatever capacity you're in, if you haven't met a client with SIBO yet, or a patient with SIBO yet, you just don't have that many patients or clients because you are so bound to find this. And I can't even count on all my fingers and toes and everything else, any other appendages, how many clients with SIBOs that I've helped out. And you really have to know your stuff when it comes to that, because I know the recurrence rate is high. So you have to know what you're doing, right?
Yeah, it's so true. Thank you so much, Jody. Okay, should I go ahead and share my screen?
Please do.
Okay, I've got a PowerPoint presentation for you.
Yeah.
Okay, are you seeing my screen?
Sure am.
Perfect. Get the slideshow going. There we go. Okay, so my topics today, as you mentioned, let me just get to my proper notes here, are going to be on SIBO treatments that really work, and managing recurrent SIBO symptoms and basically relapse. But first, I just want to do a brief introduction to SIBO in general for anybody who isn't already familiar with it, so we can be on the same page. So the definition of SIBO, a new definition was put forward in 2020, and it's a clinical syndrome of excess GI bacteria colonizing the small intestine, causing gastrointestinal symptoms. And so what this new definition makes sure to have is you need both a positive test, and which is a breath test for SIBO, and gastrointestinal symptoms to be able to diagnose SIBO. So a key point here is that you can't diagnose it just on symptoms alone, technically, officially. Now, is it an infection? Not technically, because it doesn't meet all the criteria in the definition of an infection, but we all know it behaves very much like, and really is, an opportunistic chronic infection. Chronic infections are different than acute infections. And what this means for us treating SIBO is that we need to treat until we get effects. And typically we find that multiple rounds of antibacterial treatment is needed. And it also means that patients may not feel symptom relief after just one treatment round, particularly if their gas level, their overgrowth of SIBO, is moderate to high. So just a quick snapshot over on the right-hand side of the pathophysiology. What's going on here is microbes, the bacteria represented by this little Pac-Man, they're overgrown in the small intestine, which is all of this colored area here, all the 3 different colors. They eat the host's food, and specifically carbohydrates represented by the delicious brownie. And then they make gas, they ferment the carbohydrates into gas, and that fills the intestines, the small intestines and large, and then that causes the symptoms. And that's how we get our diagnosis. Our testing methodology is the breath test, which measures the gas that the bacteria produces. There are a lot of symptoms for SIBO, and the problem is they're the same symptoms as about 40 other diseases, as you can see from looking at this slide. So let's go over it. The symptoms can range from mild to severe, and the keynote is that they come from eating. The main symptoms are the same as those of IBS in pink here. Abdominal bloating, pain or discomfort, diarrhea, constipation, or a mixture of the two. There can also be excessive belching or flatulence. Food reactions in general, especially to carbohydrates, they can have these symptoms, gastrointestinal symptoms, or systemic symptoms, particularly if there's leaky gut. Acid reflux is actually a pretty common symptom of SIBO. Nausea, food sitting in the stomach, anxiety and brain fog are very common. Depression can occur. Fatigue is very common, and weight loss or weight gain, actually. So as you can see, since they are so similar to so many other diseases, we really do need a test to diagnose it. How do we know someone has SIBO if they come in with these symptoms? We suspect it, but we need to diagnose it with a test. Now, over on the right, Jody already mentioned this, but the prevalence, SIBO is common. We know that from studies that the majority of IBS patients, 60 to 70%, their IBS is due to SIBO. And we know that IBS affects anywhere from 10 to 20% of the population worldwide. And that is actually a very vast number when you start looking at statistics. Like, I think diabetes is about 6%, 6 to 8%. So 10 to 20% is massive. And also, as Jody mentioned, what's our prognosis? Well, it's chronic for the majority. 1/3 of cases do resolve. That's phenomenal. But 2/3, the majority, are chronic. And this is usually due to there being chronic underlying causes that are continuing to cause the SIBO. Okay, so that's our brief overview. Now I'm going to just dive right into treatment, because this is what everyone always wants to know about the most. So my question is, although it's kind of rhetorical, do any of you feel confused about what to do for your SIBO patients? Or do any of you have problems with your SIBO treatments working? And if so, you can type it in the chat, because misery loves company. So if you can relate, basically SIBO can be very tricky to treat and frustrating to treat. But hopefully I'll help clear some of that up. What really encouraged me to want to talk about this topic is a conversation that I had with a colleague who's a functional medicine practitioner, very active in the online gut health world. And he told me that many practitioners that he interacts with online found that, or thought that, SIBO treatments don't work. That's what he was hearing. And there could be many reasons for people saying this, but from the conversation, it seemed that they were using different treatments, specifically different herbs and supplements than to kill SIBO, for killing SIBO, than what I use and what I'm going to share today. And what I use actually really does work. And so the first thing that I want to do is explain how I know that the treatments work. So along with Dr. Steven Sandberg-Lewis, I started the first ever SIBO specialty clinic in 2014 at the medical university where we both teach. I've been teaching advanced gastroenterology at NUNM since 2013 with Dr. Steven Sandberg-Lewis. And I was the medical director of the SIBO center there for all the years that I was there. And we had other doctors that worked with us in this clinic and in the community. And being a specialty clinic meant that all of our patients were SIBO patients. So every patient all day had SIBO or suspected SIBO. So that was all we saw. And we ran before and after tests for every treatment that we gave. And so we got a lot of immediate feedback and data to show us what treatments were working and what treatments weren't working. And we also created herbal antibiotic SIBO protocols, because there weren't really any that existed at the time back then. This was like 2010. And we did consult with several experts to create these, including Stephen Bruner, who is a medical herbalist and wrote the book Herbal Antibiotics and edition 2 of Herbal Antibiotics. And so anyway, we were able to create these protocols. This was in 2010, 2011. And then we refined the protocols and doses over many years with our patients with before and after testing. And then we began sharing and teaching the protocols in articles, and at the SIBO conference we created the first ever SIBO conference called SIBO Symposium in 2014. And that has continued until COVID. And then nothing has happened so much during then. By the way, on this screen, these are before and after tests of a patient of mine with that we used one of the herbal antibiotic protocols we created. And you can see the hydrogen here. The hydrogen is as high in the first 2 hours as 65 and 78. Let me see if I can get a laser pointer. Here we go. Here we go, right here. And then she was treated, and now her test is negative. She's down to 4 of hydrogen. So the other thing we did was develop this SIBO treatment algorithm also back in 2010, and then we updated it through the years. It's adapted from Dr. Pimentel's algorithm, which he spent quite a lot of time validating, about 7 years of researching and publishing on the various steps here, and then using it with his patients. Our version includes herbal antibiotics and clarifies steps that weren't represented originally. And I just think it's absolutely vital to have this type of game plan and know what your steps are for SIBO. Many practitioners don't have a map or an algorithm that they're using or in their head, and they miss critical elements, or maybe they just don't have all the steps and timing put together, and they wind up not getting the outcomes that they and their patients want. We were able to get really consistent outcomes with this algorithm. Plus, having something like this helps decision fatigue, and it gives confidence in your treatment approach. So I mentioned Dr. Pimentel. Here he is pictured. He is the leader in SIBO research since the early 2000s. He works at Cedars-Sinai Medical Center in Los Angeles. I was fortunate to be able to observe his practice back in 2014. That was the same year we had our first SIBO symposium, at which he was a speaker. He's an extremely prolific researcher, and he's been tackling all of the issues and questions that we all have about SIBO and IBS one by one over the years. And he's also currently mapping the small intestine microbiome, which has not been done yet. It's been fascinating to watch that research. So we're just all very fortunate to have him working to help us all. I mention him a lot because he's the primary researcher. I'll keep mentioning his studies, so I wanted you to know who he is in case you didn't. Okay, and so then the other thing we did at the SIBO Center was we used all 3 treatment types with our patients: antibiotics, herbal antibiotics, and elemental diet. Those are our 3 main treatment types. And we did it with before and after testing. And that gave us really great experience with all of the treatment types. And many practitioners, unfortunately, don't have that experience because they stick to only 1 or 2 types. And this could be because they're limited by their license, or it could be philosophy, but one way or the other, it was very helpful to have that experience. And lastly, we met together as a team and shared our experiences, and this exponentially increased our learning because we had the benefit of other doctors' experience in patient populations, and that gave us a larger patient sample and more data. And so that's the story of how it is that I know that these treatments that I'm going to share that I use actually do work. It's because of extensive data with before and after testing, as well as symptom tracking of really thousands of SIBO treatments given. Now, if somebody here, as I go through this, or maybe you already know what these treatments are, if you use these treatments and you think that they don't work, I actually have some points for you at the end. I'll go over. So hold tight. As mentioned, our 3 antimicrobial treatment types are herbal antibiotics, elemental diet, and pharmaceutical antibiotics. 2 of the 3 are natural. There are 3 gases the overgrown microbes make: hydrogen, methane, and hydrogen sulfide. And a 4th category is when 2 or more gases are positive, and we call that mixed. These give us our different types of SIBO. And treatment is based on the gas when we're using herbal antibiotics or pharmaceutical antibiotics. So we use different herbs or antibiotics based on the gas. Elemental diet, however, works on all gases. The reason that herbal antibiotics and antibiotics vary by gas is because different microbes make different gases. So we need different antimicrobials depending on the microbe we're trying to kill. So in SIBO, hydrogen is made by E. coli, Klebsiella, and a little bit of Aeromonas. Methane is made by Methanobrevibacter smithii, M. smithii. And this is in the category of archaea, not actually bacteria, although it's just a microorganism extremely similar to bacteria. Now, breaking news, just released 3 weeks ago at the biggest GI conference, Digestive Disease Week, is that hydrogen sulfide is made by Fusobacterium species. One study did show Fusobacterium varium and Desulfovibrio. So this was just presented 3 weeks ago. In fact, it's so new, this research, that we have 2 animal studies, 1 human study on stool. We don't actually yet have deep sequencing of small intestine yet. I'm sure that study's coming, but this is new research.
Wow, that's awesome.
I know, isn't that exciting?
That is.
We've all been waiting for Dr. Pimentel to release this. We expect treatment studies based on this to come next, of course.
Tell all your colleagues to join our group so they can see this presentation. This is really awesome. It's great to have such research behind this.
Another quick research update. Dr. Pimentel and team have come up with a new name for the hydrogen overgrowth with E. coli and Klebsiella, and they call them disruptor taxa, the E. coli and Klebsiella. That was published in the fall of 2021. Basically, we used to think that SIBO was just about the overall amount of bacteria being too many, but now we know instead that it's specific bacteria that I just mentioned, or archaea. And in the case of E. coli and Klebsiella, hydrogen SIBO, when they overgrow, they disrupt the entire small intestine microbiome. So this is a picture. These pictures are courtesy of a research update interview he did with me in February. So this is a normal representation of what the small intestine microbiome should look like. And here's what it changes to in hydrogen SIBO. So our understanding has changed over time. We now know these specific bugs. And it does make sense that we have to vary our treatment based on which microbe we're trying to reduce. We know that different antibiotics are used for different conditions depending upon which bacteria or microbe is present. Previously, all of the gas types were called SIBO. Everything was just called SIBO, but now methane SIBO has a new name. It's called intestinal methanogen overgrowth, or IMO for short. And this is to account for the fact that methanogens, M. smithii, are actually archaea, not bacteria. So the B in SIBO for bacteria has now been changed to an M for methanogen overgrowth. And also methanogens can overgrow in the large intestine too. So instead of just small intestinal, it's broader, it's intestinal now. So it's the same old methane constipation type SIBO that we've always known. It just has a new name. So also you can see on this slide, the gas types go with the bowel movement pattern. So we know that hydrogen is correlated more with, I don't have it on this slide, but I can just tell you, I thought it was here. Hydrogen correlates with diarrhea, methane with constipation. Hydrogen sulfide can actually be either, although in the research studies, it correlates more with diarrhea. And then when we have mixtures of gases, we can either get a mixed picture or sometimes one predominates and we get a single picture. Now, the other important thing to know as a background to understand SIBO treatment is that hydrogen is converted into methane or hydrogen sulfide gas by the methane or hydrogen sulfide microbes. And because of this, we use double antibiotic therapy for patients with methane, hydrogen sulfide, or mixed gas. So one agent is for the hydrogen producing bacteria, and then another is for the archaea that make methane or the bacteria that make hydrogen sulfide. Additionally, since the microbe that produces methane is an archaea, not a bacteria, we find that it takes different and extra antimicrobials to kill it. And this is a really key point that can be missed in SIBO treatment, understanding the double antibiotic therapy and that we need double and different for the different gas types. But what all these things I'm saying here applies to antibiotics and herbal antibiotics. Elemental diet is effective as is for all gas types, and I will be going over that. Okay, so for antibiotics and herbal antibiotics, What we used and tested was 1 or 2 antibiotics or herbal antibiotics at a time. In the beginning, we tried the herbal combination, herbal antibiotic formulas that have a lot of different herbs in them. We tried that, but we stopped using it because we found we needed better control of dosing of what we were doing. And it was a lot better for our sensitive patients who react to many different herbs if we just used 1 or 2. And really the key reason we stopped is because we found with our testing that more herbs don't reduce gas any better than 1 or 2. So why use more? Why not just use 1 or 2? The duration of treatment for antibiotics, typically it's 2 weeks. Sometimes we go to 3, and that would be 1 treatment round. For herbal antibiotics, it's twice as long. It's 4 weeks, and sometimes we go to 6 weeks. So the reason we would go longer, 3 for antibiotics or 6 weeks for herbal antibiotics, is in higher gas scenarios where hydrogen or methane is above about 45 or 50 parts per million. Typically, we found that there was minimal added benefit going longer past this time. I really wish that that wouldn't have been the case, because then we could have just put someone on something until it was done. But what would happen is the effect would peter out over time. I mean, that's the case with antibiotics, for whatever infections, that you just don't go on forever. But unfortunately, their effects would peter out and patients would actually begin relapsing while still on the treatment if we kept it going too long. Not everybody. I've certainly seen cases where herbs were effective, and some doctors just happen to have a patient population where they don't see that. But honestly, I saw it so commonly. So we stop after a certain amount of time. Okay, now for herbal antibiotics. For hydrogen, we use berberine, oregano, or neem. Berberine is a constituent that is in various different herbs like golden seal, oregano, barberry, philodendron, coptis, and yerba mansa. So these are the 3 herbs we use for hydrogen. For methane, we use allicin, which is an extract of garlic, or atrantil. So the product that we actually used for, that was the Allison product was Alimed, also sold as Alimed Plus. What we don't use or recommend is whole garlic, aged garlic, or garlic oil, because there's high FOS in that, fructooligosaccharides, which can trigger the symptoms for SIBO patients. Atrantil is a small herbal combination formula. I'll mention more in a minute about that. For hydrogen sulfide, we use bismuth, high-dose oregano, or uva ursi. And when we have mixed gases, we mix these together. So I'll show you what it's like for each herb. For hydrogen, we're using berberine, oregano, or neem, and usually we use 2 together. So berberine plus neem, berberine plus oregano, or oregano plus neem. For methane or hydrogen and methane together, we add allicin or atrantil to one of the hydrogen herbs. So it would be berberine plus allicin or atrantil, neem plus allicin or atrantil, oregano plus allicin or atrantil, or you can use atrantil by itself sometimes too. That I wouldn't do for the combination, just for methane, you could do that. Atrantil has a different mechanism of action than the other herbs. It has some antimicrobial killing action, but primarily it blocks the production of methane by the archaea. And due to this, I find it's a bit more hit or miss. When it hits, it's a miracle, honestly, but it can miss. So it just isn't a very strong killing agent. For hydrogen sulfide, we find a single agent is often effective, but we also use double therapy. So we either use bismuth or high-dose oregano. So bismuth or bismuth thiol complex, I'll explain in a moment, high-dose oregano, or use them together, high-dose oregano plus bismuth or bismuth thiol, or high-dose oregano plus uva ursi, bismuth or bismuth thiol plus uva ursi, or uva ursi plus silver. Bismuth can be obtained as Pepto-Bismol or generic forms of it. And you can also compound it as bismuth subnitrate. Not every compounding pharmacy will do it, but most will. Bismuth thiol complex is Dr. Paul Anderson's anti-biofilm formulas. He has 2 versions. One is a compounded formula, and the other is over-the-counter by Priority 1, and it's biofilm phase 2 advanced. And how bismuth works for hydrogen sulfide is it's both antimicrobial and it binds hydrogen sulfide. Okay, now what if you have mixed gases for and you're using herbal antibiotics? For hydrogen and methane together, you use the methane protocols. Whenever hydrogen sulfide's in the mix, we add either bismuth or bismethiol or high dose oregano to whatever protocol was already going to be set from the other gases. Obviously, we're still figuring out what the best options are going to be for hydrogen sulfide. The research is new, but I can tell you before and after testing with this does work very well. Okay, that's it for herbal antibiotics. Now, elemental diet. Elemental diet is a medical food beverage of pre-digested, easily absorbed nutrients that usually comes in a powder form. Some you can get in a liquid form. So the proteins are amino acids, the fats are oils, the carbohydrates are glucose or maltodextrin, and then there's vitamins, minerals, and salt. And the mechanism is different than herbal or pharmaceutical antibiotics. It's starving the bacteria instead of directly killing them like with a hammer, but the patient is getting fed because the pre-digested nutrients absorb very quickly and in the top of the small intestine before they can be consumed by the bacteria. And it works for all gas types. Thank goodness. A very key point about this treatment is that it can significantly decrease gas levels or the overgrowth in 1-2 week course, up to 150 parts per million, which is very excellent. And this can save a lot of treatment time having to go through multiple rounds of antibiotics or herbal antibiotics when a patient has higher gas. And this matters because we typically need multiple successive treatment rounds in SIBO, especially with antibiotics and herbal antibiotics. It's normal to need 3 treatment rounds, 4, 5 treatment rounds to get a test negative. That's actually normal. 2 to 4, I'd say, is average. And I call that time and fine. And that would be in comparison to one and done, where 1 treatment round takes care of it. That happens too. Those are the fabulous, wonderful cases. But more often than not, more than 1 treatment round is needed.
How much time between treatment rounds do you generally take?
Yeah, so typically what we do is we don't want to let it go, if possible. And this is what's really hard for our practices, more than about 2 weeks. And the reason why is that backsliding at 2 weeks is very common. And so it's basically like we're not done with treatment and we need to keep going. So many people will just assume more is needed and just have another treatment round of something different ready to go. But the problem is sometimes the SIBO is actually already gone and there are symptoms remaining because they're from something else that somebody also has. And so you don't want to just assume for too long. You want to retest. So since I was in a specialty clinic, I retested after every single treatment because patients were wanting that actually. So the way that I do it is you retest pretty soon after you finish the first round and then try and get those results back pretty quick before that 2 weeks is up. And then you can watch what's happening with the symptoms on the patient and you see the test and then you make your decision that informs you of what your next treatment round is going to be if it's still positive. So try not to make it too much longer than 2 weeks, and you can do it right away, but just be sure they still have SIBO. That's what you're treating. And there are some other tips about that I can go into a little bit later.
Just one other quick question. Maria wants to know, is D-lenolate, which is olive extract, considered an herbal antibiotic?
I think of olive as more of an antiviral, and I never did do before and after testing with olive. Mm-hmm. I have had people come to me on olive from other practitioners that wasn't successful. That's not really a good judge though, because when that happens, you're only seeing the failures, but that isn't what we used. Okay. So now another key point that I don't have written down here is that antibiotics and herbal antibiotics reduce hydrogen and methane gas per treatment round, on average, about 30 parts per million of gas. So the breath test measures in parts per million. So elemental diet in comparison reduces more than double. So I'd say about 70 parts per million on average versus the on average 30 for antibiotics and herbal antibiotics. So if someone has gas of 80 parts per million, let's say hydrogen, we typically need 2 or 3 treatment rounds with pharmaceutical or herbal antibiotics to normalize that gas and get that SIBO gone. And if you were using herbal antibiotics, that could be 2 or 3 months. But we could be done in 2 weeks with elemental diet. So that is the key special thing about elemental diet. Now, here's what's hard. It's drunk in place of all meals for 2 weeks, sometimes 3, just like you would do pharmaceutical antibiotics. It's a 2-week course, sometimes 3. No solid food is eaten. And that is challenging. And that is why, despite its ability to shorten overall treatment time, many patients will try this treatment last because they don't want to deal with this. So I definitely think how we present it makes a big difference. And if we're very positive about it, we can also put forward the sort of fasting aspects, the spiritual aspects of fasting, and it's not actually fasting, but it's kind of a type of fast. Then we can get more buy-in. But of course, we don't want to pressure, or, it has to be right for the patient. The protocol set forth by Dr. Pimentel, he did a study on this, excellent results, is you do it for 14 days. Then you retest on the morning of day 15. The elemental diet on day 14 is like your prep diet. And you want to get the results back, if possible, very quickly. You could ask for overnight results from your lab if they can do it, and they might charge you for it. Because if the test is still positive, then you would continue on for a 3rd week. Most patients don't want to do that, but if they have the retest, they might be convinced to do it and get it all done. Sometimes patients say, no, I'm done. And then you just move on to a pharmaceutical or herbal antibiotic after that. Of course, if the test is negative, then you stop and you begin your prevention treatment. And here I've listed some brands of elemental diet just so you have a sense of what they are. Vivinex Plus at the top is the formula that was studied by Dr. Pimentel for SIBO, but clinically we find other formulas also work. And at the bottom, I do have homemade recipes. I developed those because back when I started, that was like 2012. Back then, we only had Vivinex Plus and Neocate Jr. None of these others existed, and they're pretty expensive. Vivinex, and my patients, honestly, they just couldn't afford it. Now, these other brands have gotten much more affordable. And any of you already familiar with elemental diet certainly know there are a lot of intricacies to know about when putting someone through this protocol. And I go over all those nuances and details in the SIBO Pro course that Jody mentioned, the 20 CME Pro course, as I do with all the treatments. So lots more for you there. Okay, now on to antibiotics. So we have 4 main antibiotics we use. Rifaximin is used for hydrogen, as well as at the bottom, hydrogen sulfide. And then in the middle, we use neomycin or metronidazole or nitazoxanide for methane. And we mix these when we have combinations. So for hydrogen, we use rifaximin. That is sold as Xifaxan in the US, but it has other names depending upon the country that it's offered in. For methane and hydrogen and methane together, we use rifaximin plus neomycin, or rifaximin plus metronidazole, or rifaximin plus nitazoxanide. So rifaximin is for the hydrogen bugs, and the neomycin, metronidazole, or nitazoxanide is for the methane bugs. Super important. And for hydrogen sulfide, we use rifaximin. That's especially good for the diarrhea type. When there's constipation or a combination of methane, we can add neomycin. Or we can do rifaximin plus bismuth or bismuth thiol, or rifaximin plus high-dose oregano. These are very common that we use these combinations here, these bottom 2 combinations in hydrogen sulfide. Rifaximin is, as you can see, the core of all of the pharmaceutical antibiotic treatments. It's used for all the gas types. And if you are not familiar with it, it is truly an amazing medicine because it is not a typical antibiotic. It actually helps improve and restore the microbiome. We've known for years in studies that rifaximin actually increases lactobacillus, bifidus, and Faecalibacterium in the large intestine microbiome. But recently, Dr. Pimentel mentioned that rifaximin actually restores the small intestine microbiome from this abnormal to this normal in the small intestine. So it can help both the large and small intestine microbiome. Really astonishing. Rifaximin has many other benefits, and I go over all of those in the pro course. Okay, now I'm done going over the 3 main treatments, and I want to talk briefly about what if those treatments that I've shared, you do them and you don't think they work. So first off, don't judge by symptoms. Retest to see if gas is actually lowering, because symptoms can take 2 or 3 treatment rounds to get better if gas is high. Second is just know not every treatment clicks for every person. That's just the case in all medicine, all conditions, all options we have. So like you might find you're using a certain treatment and it works in patient 1, patient 2, but it doesn't work in patient 3. Treatments are not universal to everyone in every situation. Just try a different treatment if that happens. Don't be like, oh my gosh, everything's awful. Just pick a different treatment for that person. And sometimes only one of the 3 treatment types works for a person. That is actually very common in my patient population. And this is why it's important to vary the treatment between antibiotics, herbal antibiotics, and elemental diet. I know that can be hard based on licensure and what one has ability to prescribe or not, but just try not to limit your toolbox. And last is, you might really have a tough case. And so what I'm defining as a tough case in this situation is when multiple appropriate treatments, like the ones I've mentioned, don't reduce gas or symptoms, or only offer minimal temporary help, like they're resistant to treatment. Usually this is due to something else going on, like mold illness or mast cell activation syndrome. And these types of things need to be dealt with first before you're going to be able to get anywhere really with SIBO treatment. Okay, so we just covered this area on the algorithm, and I'm going to do my next topic. It's briefer, but before I do, I just want you all to think about a SIBO patient that you might be working with right now. Think about their symptoms and think about what you've tried that hasn't worked. Maybe they've tried those things with someone else, and think about the treatments that I just discussed and see, is there something that you haven't tried with that patient that you think might work? And if so, write it down so you don't forget.
A couple of questions here, lots of questions actually.
Yeah.
This has been fantastic, wonderful, wonderful information. I'm sure it's going to help so many of us. But I'm wondering, there's a question here about, can H. pylori contribute to it, overgrowth with SIBO, SIFO, IMO? How do you treat that in relation to SIBO treatment? And do you find the herbal antibiotics are effective in treating that as well?
Okay, I am not an H. pylori expert. I can't really go over from clinical experience, having treated a lot. No, I haven't. Mm-hmm. It is not really thought to be a main cause of SIBO, but it can certainly be coexisting. And for treatment, there's pharmaceutical double, triple, there's quadruple therapy, and there's herbs, but I cannot speak to true effectiveness because I haven't put people through those protocols and watched for relapse. I know it can be very hard to treat. Antibiofilm is usually used in that.
Yeah,
so
in my clinical experience with H. pylori, since it gets in the way of breaking down proteins, it can definitely contribute more to the development of SIBO, right? Because of all the intestinal fodder.
I mean, it makes a bad
bacterial fodder in the intestines. What's that?
Milieu and environment, but it doesn't, like, what are true causes of SIBO is like slowing of the migrating motor complex, and I don't think H. pylori does that in the studies I've read, but please don't hold me to that. So because I'm not a complete expert on that one.
Right. So many other questions, and I know we want to talk about, well, I'll ask a couple more at least now, and then we can, maybe go over a little bit about how your course works if people are interested as well. Because actually I was looking at the price point, and for 20 CMEs, this is probably the best bang for your buck, even if you weren't interested in this information. But I know
I really tried to price it affordably.
Oh my gosh, it's wonderful. And it's very affordable, and you're going to get a lot of CMEs for it. So that's great. But this question here about treating children with SIBO, have you worked with children at all? Or
yes, it's common in children. We can use almost all of our treatments that I just discussed for children, except there aren't really good studies on the safety of oregano. Neem oil is unsafe. However, we have used neem neem capsule powders, opened up. We use everything, typically at half dose, sometimes even less than half, depending on the weight of the child. I have the specific dosages all in the pro course for all of the antibiotics for children. They've been studied in SIBO or in similar conditions. One thing that I didn't mention that is an herb is herbal combination that we found to be very effective in children that I have not found to be very effective in adults is biocidin. Biocidin. A lot of people love that product and ask about it. We think it's great for pediatrics. We don't use it for adults in SIBO. So those are some of the differences. I'm going to now next get into the prevention treatments, which are extremely important. Mm-hmm. And we can also use most of those for children too at half dosing.
Great.
And did you want me to go on, Jody, or did you have one other question?
Well, there was one other just about the breath test identifying the specific type of gas, and it does, right? But there's limitations there as well.
Okay, so almost all the machines that are out there today are mostly made by Quintron throughout the world, generally, not all, and they test for hydrogen and methane gas. Now, there are some facilities like hospitals that have older machines that don't test for methane. So you do want to ask and be sure that your facility, that machine tests for hydrogen and methane, and you want to be sure that they're reporting that, because facilities like hospitals that don't do much testing might not even report the methane. So just make sure. Most of our tests are gotten from a mail order. So almost all of those do this, but there's a new methodology to test for hydrogen sulfide. And that's only available currently from one manufacturer, and that's Gemelli Labs, and that's called TrioSmart. And that tests all three gases. And that's been out for about 1.5 years. It's quite new still. So to my knowledge, that's the only place to reliably test for hydrogen sulfide. What we were doing previously is we would look for a certain pattern. Obviously, the booklet and the course, I go in depth into interpretation and testing, which is very briefly. There's a flat line pattern that we were using to indicate hydrogen sulfide. What's been very interesting that, when we're not testing for hydrogen sulfide, when we just have hydrogen and methane. But what's been very interesting is now that we have testing for hydrogen sulfide, we're finding that flat lines don't always correlate with positive hydrogen sulfide. And we're trying to figure that out right now. Oh. So yeah, that's testing. But, you can still do hydrogen sulfide is a smaller portion overall statistically of cases. So you can still do extremely well with hydrogen and methane testing. And then you can look into TrioSmart. The reason I'm saying it like that is because TrioSmart is only available in the US currently. So anyone in another country doesn't even have that available to them, but we've done great work with just hydrogen and methane. So don't worry, just use that.
Well, this is great. And I just want to throw in here, if any of you are interested in this course, Terry has posted, and I think Aaron has posted the link in the chat or in the thread below here. And we will be sending a replay to anyone who's on our email list as well. But if any of you are interested in purchasing this course, Dr. Siebecker has generously offered to give a bonus course free for those of you who sign up for her course by June 15th. So that's coming up pretty quickly. Today's the 9th. So just a few days, if you decide you'd like to do the course, and tell them about the bonus course that you are going to be offering.
Well, I saw in the questions, people submitted a lot of questions about parasites and how they relate with SIBO. And we have a masterclass course from Dr. Alana Gurovich, all on parasites. Are not my specialty, but they're hers. And so she teaches everything and everything you can think of about parasites and how to treat them. Parasites and SIBO coexist extremely frequently. And so this will give you all the details you need.
Excellent.
Okay, so should I just finish my last little? Okay, yes, thank you so much for putting that in there. Those questions, Terry. Okay, so next is this is how to manage recurrent SIBO symptoms, and really it's about helping people that continue to have some amount of symptoms that go on. They struggle with chronic SIBO. Maybe their SIBO gets better, we treat it, it gets better, but then it relapses. And I know that it can seem like SIBO is a losing battle generally because of the perpetual relapse cycle. But usually these people have ongoing underlying causes that are both continuing to cause the SIBO, but also generating symptoms on their own. And some examples would be things like endometriosis or Ehlers-Danlos syndrome. Both of those generate GI symptoms on their own and also can cause SIBO. Obviously, we have to identify, if we can, identify and treat the cause. That's very crucial. But I want to just also talk here about addressing and managing their symptoms while we're trying to do that, because that's very important. So as I mentioned at the beginning, statistically, we know that about 2/3 of SIBO cases are chronic relapsing, primarily due to a presence of an underlying cause. But unfortunately, many of these underlying causes are currently incurable. People are working on them. So for example, the most common cause of SIBO is food poisoning. And food poisoning creates autoimmunity to the small intestine nerve cells. And there is no cure for that autoimmunity currently. It's being actively researched. Also, the cause might be complicated to eliminate, like takes a long time, like Lyme disease. Lyme disease can cause SIBO. And we know those treatments usually last about a year or two. It can take a while, not always, but so patients like that, and in the food poisoning scenario, we are going to be dealing with ongoing symptoms for a while and recurring SIBO. So what are our methods for dealing with this? First, find and eliminate the underlying cause if possible, has to be stated. Next is the SIBO diet. There's lots of SIBO diets we can use. They're excellent at symptom relief, but they're challenging, and we have to be careful our patients aren't restricting too much, but they're particularly helpful for chronic SIBO. Also included under this heading would be meal spacing, which is no snacking between meals or consuming caloric beverages. And this is to allow for the migrating motor complex to happen. I'll mention more about that in a second. Third is supplements. We have all kinds of supplements that can help manage SIBO symptoms, and they are very, very helpful. I devote really quite a bit of time to this topic and to the diets in the SIBO Pro course. So I'm not covering these today here. What I am covering is number 4, Prokinetics. So I'm going to focus on that. So Prokinetics, which I'll define in a second, they come in 2 places here on the algorithm. First is right after we finish the antimicrobial treatment. So Jody had asked earlier, how soon do you move to the next round? Of key importance is if there's going to be a little bit of time before you're moving to the next round, which I usually have because I'm retesting. During that period where they're taking the test and then you're waiting for the results, you want to be sure they're on a Prokinetic, and that is to hold the gains that they've made so they don't backslide really quickly until you can get them their next treatment round. And then the next place is once SIBO is eradicated for prevention. Now, I'm going to describe them in a minute, but I just want to say that this is one of the most commonly missed steps in overall SIBO treatment. A colleague of mine has a SIBO patient Facebook group with like 22,000 members. And she says that so many of these patients don't use a Prokinetic. Their doctor might not know about it. And they just struggle and struggle and struggle with the relapses. So, and I think there isn't enough education on the critical role they play. So here we go. What are they? They are medicines that amplify and coordinate gastrointestinal motility. And we have both natural and pharmaceutical options. They've been studied for SIBO and shown to extend the remission time after successful eradication, which means they can prevent relapse. And the average relapse time of 2 months in studies. So when somebody first gets diagnosed with SIBO and is first undergoing treatment, usually their time that they're going to relapse is sooner than as we keep working with them. It gets better, but in studies, it shows about 2 months is the average relapse time. Prokinetics can extend that to 4.5 to 8 months, which is incredible. So our patients can gain 2.5 to 6 months of remission time by using a Prokinetic if they didn't, or put another way, they can prevent relapse for 4.5 to 8 months. These are incredible rates, and that's why we use Prokinetics. And that's why prokinetics are on a list of ways to manage recurrent SIBO symptoms. It's because they delay the relapse of those symptoms. So phenomenal results here. Okay, what do we do in terms of dosing? We dose them always before bed, and that is to stimulate the migrating motor complex overnight. And that's their mechanism. That's what they're doing for us here, is they're stimulating the migrating motor complex, which is the primary protection that the body has against SIBO. It's a movement, like a motility in the small intestine that sweeps bacteria down and out of the small intestine. And it does this during fasting. So that's between meals and overnight while we're sleeping and we're not eating. And they are specific, these medicines are specifically designed to stimulate the migrating motor complex. That's pretty much their intention. So we give them before bed to stimulate the migrating motor complex overnight. So we can clear out bacteria and archaea each night out of the small intestine. And that's how it works to help prevent SIBO from coming back. So when do we start them? We start them very soon after the antimicrobial treatment ends, either the next night. So day one, that after antimicrobial treatment ends, that night. Or you could wait a few days. Sometimes I wait a few days because I want to sort of see what the patient's symptoms are now being off their antimicrobial treatment, maybe for just a day or two, because sometimes it's confusing. If you start a new medicine, I see a lot of very sensitive patients where they react to a million different things. And sometimes they might start reacting to what you just gave, and you confuse that with, what you just did in your SIBO treatment. So giving a day or two is kind of nice. But because it started so soon after antimicrobial treatment ends, logistically, it means that we want to give the patient the prokinetic treatment plan at the same time as the antimicrobial treatment plan, because it's going to start right afterwards. And just as a side note to help everyone contextually where this comes in, this is a slide from the SIBO Pro course on appointment visit flow and when to do what. And typically the second appointment is when we're giving antimicrobial treatments. And then that's the great time to also give the prokinetic plan. They're not going to start it yet, but you tell them what they're going to do when the antimicrobials stop. Okay, so what are our prokinetics? Pharmaceutically, we use low-dose erythromycin, low-dose prucalopride, and low-dose naltrexone. Low-dose erythromycin, erythromycin is an antibiotic, but in low dose, it works as a prokinetic. And we have many, many studies on this. And it's one of the standard treatments for gastroparesis, which is slow stomach emptying. Prucalopride is sold as Motegrity in the US. It's sold as usually Resilor, Resitran in other countries. And it is the safest and strongest prokinetic pharmaceutically that we have. It is excellent and has many beneficial properties like nerve repair, which is very helpful for SIBO. And LDN is famous for balancing the immune system. It's used in autoimmune conditions, decreases inflammation, helps depression, and much more. Technically, it's not a prokinetic, but studies show that it has a prokinetic effect. For the natural options, we have herbal prokinetics. So Iberogast is a 7-herb combination formula originally from Germany, used for over 45 years clinically and with like 35 studies on it. And there's been studies done head-to-head against pharmaceutical prokinetics, domperidone and cisapride. We don't use domperidone and cisapride in SIBO because they have safety concerns. The ones we use are predominantly safe. And anyway, Iberogast performed better for dyspepsia than these pharmaceutical prokinetics. Ginger root is famous for helping nausea, and that is due to its prokinetic effect. It stimulates stomach emptying. And then we have ginger-containing prokinetic formulas. And I've listed all of the ones that I know about here. There might be more. So they just have all these different names, and they all contain ginger, and some of them also contain 5-HTP. And they're all over the counter. So one very important point is that for the more chronic cases, where there's very difficult chronic cases, often natural prokinetics aren't strong enough. So if you've been disappointed, if you've been using natural prokinetics, herbal prokinetics, and you've been disappointed in the prokinetic effects, that could be one reason why. Prucalopride is definitely our most effective option. Okay, couple of ending points here. Prokinetics are not laxatives. That means we can use them in SIBO diarrhea patients. And these two types of medicines really get confused easily, but they have different functions and purposes. Prokinetics amplify and coordinate GI movements, whereas a laxative loosens stool and produces bowel movements. And prokinetics don't have that definition or function. If a prokinetic does happen to stimulate bowel movements in someone, first of all, just know that is probably the most common side effect of any medicine other than headache. So don't freak out, just lower the dose or switch to a different prokinetic, but don't give up on the category of prokinetics. They're just too important for chronic SIBO. And the converse is also true. Laxatives are not prokinetics. And so that means magnesium or the prosecretory agents like Linzess, Amitesia, Trulance, they don't stimulate the migrating motor complex. High dose vitamin C, things that people are using for laxatives don't stimulate the migrating motor complex. So we need, even if a patient needs a laxative, they will additionally likely need the prokinetic for their migrating motor complex. How long do we do them for? Typically about 3 months in the beginning, just to get someone through that typical relapse time of 2 to 2.5 months. So we want to see how they're going to do, to kind of get them past that rough patch where they're likely to relapse and reevaluate. However, many patients that have an ongoing underlying cause are going to need them ongoing. They're going to need them long term. And one of the most common questions that comes up is, do you continue a prokinetic if you're doing another treatment round with antimicrobials? And the answer is you can, but you don't have to. So either way is fine. Either way is fine. Where this comes up a lot is with something like LDN, which we typically start low and titrate up. So then a person goes, well, if I stop it during the antimicrobial round, am I going to have to do that again? Well, you don't have to stop it. You can take prokinetics during treatment rounds, but you don't have to. Okay, so here it is circled again where they exist on the algorithm. And like our treatments, just take a moment and see if you can think of any patients that you have this could apply to. Do you have any patients that haven't tried prokinetics between their treatment rounds or after eradication? Do you have anyone where their symptoms keep returning and they relapse a lot, but they're not on a prokinetic? Or did you try a natural prokinetic and it didn't seem to help enough? They could be a really good candidate for a prescription prokinetic. Or do you have any patients that reacted to a prokinetic or it wasn't helpful enough? Is there an option that I mentioned you haven't tried with them? So if so, write that down so you don't forget, so you can remember to bring it to them. And with that, back to you, Jody.
Okay, that was wonderful. I learned so much. My hand's getting sore from writing notes.
I'm so glad.
You're getting a lot of love on the chat too. A lot of people really appreciate you coming on today. But a few questions just about trauma and stress being a root cause of SIBO.
What I have observed in all the cases I've treated is that can be an exacerbating. It can be like the straw that broke the camel's back, like the final trigger. But I've only experienced one case, and I would be suspect that stress was the only factor. Because what causes SIBO at the physiological level is when the migrating motor complex becomes deficient, and that usually involves a disease process. Now, it's true, stress can turn off our digestive functions, right? Our secretions and things like that. It can turn off the migrating motor complex. But I just haven't seen a case where that was the true ongoing root cause. So usually it's like someone had food poisoning 10 years ago or multiple bouts, but they still didn't get SIBO. And then, they took tons of antibiotics for acne. And then, whatever, there's things that stack. They have hypothyroid. I haven't gone over causes. All of these things I'm mentioning are causes, they have hypothyroid, whatever else, all these things happen. They still don't have SIBO, but then they might have, and this is the common trigger, a 2-week intense period of stress. I've had a lot of patients, 2 weeks, and then that's it. Then they get the SIBO.
It's a big trigger. So what about diatomaceous earth? Somebody's asking about that. What's your opinion on it?
Well, I know that's used as a binder. I believe.
It's also anti-parasitic.
Oh, is it as well? Okay. Yeah, we haven't ever used that for SIBO. I have no before and after testing on it. You guys, if you do before and after testing on any of these other things, report it back to your group so everyone can learn.
definitely. And this community is very vibrant. I know we're all great at helping each other with that too, and listing new resources. Okay, question is, if patients take psyllium husk, does it help or hurt their healing from SIBO?
This is a great question in general about fiber. Fiber can be a very big trigger to cause symptoms. Fiber is a food, it's a carbohydrate, and it's specifically for bacteria. Humans don't have the enzymes to break it down, so it directly feeds them. So it can be very problematic for people. However, as with any food item or category, it's very individualized to each SIBO patient. So there are SIBO patients that can take psyllium husk and it helps them. And that's what you want to judge by. You want to judge by the individual case. So if a person is taking psyllium, they are not getting any worsening in their symptoms. And in fact, their symptoms are being alleviated. Then it's helping their healing. If it is aggravating their symptoms, it is working against their healing.
Great. And another question, somebody's asking if somebody's already taken your pro course, could they get the ebook? Absolutely.
Oh,
Everyone
God, yes.
in the group gets the ebook. So do go ahead and get that. And do you mind if I show them your pro course just for a sec?
Please, thank you, please.
So I just am really impressed by this, and I just think everyone could really benefit from it, and the price point is really, really excellent. So with the link, use my link so you get the bonus course. So Terry put that below, and Aaron put it below, so you can take a look at that in the chat and in the comments below on the Facebook thread. But you're going to get 22 hours. All kinds of material here. I don't know if you want to summarize it at all.
But again, actually, I saw someone submitted a question that said that they had already purchased the pro course, but felt so busy they weren't even watching it. And I just want to point out a couple of things about that. Most of the classes are 10 minutes, or maybe like 13 minutes. You can watch them while you're eating your lunch, or listen. You can listen like a podcast. You don't have to watch. And the other thing is, there's a physician's desk reference that I made, and people who've bought it over and over and over, they tell me that that's like their favorite thing. I have all of like the key slides, like you can just quickly go, it's got a clickable table of contents. So you can just like look up, like, I need to see what the hydrogen sulfide treatments are. And you click it and bam, it goes there. Or like, what do I need to know to tell a patient about what to do for their breath test? You click it and it goes right there. So it's the clinician's desk reference PDF. So if you're short on time, I'm short on time too. I've tried to make it friendly and accessible for you to get information without having to sit from, minute 1 to the end. So you can pop into any section. And so, so it's by category. So you should be able to find what you need quickly. And, I've got extensive references and slides. I've got a bunch of bonus guest lectures from other wonderful.
Impressive. I was going to say impressive group of guest lecturers.
Yeah, and Dr. Kapadia and Dr. Rao are experts on fungal overgrowth, so SIFO, and so many people have questions on that. And so we've got 2 master classes for you in there on that. So we're really covering all the bases. Everything's covered: testing, differential diagnosis, every aspect of treatment, from plan A, B, C, D. Like, what do you do if this fails? What do you do if that fails? On and on and on. You should be set.
And how long do they have access to the course once they purchase it? If they decide to purchase this week, so they get the bonus course?
Well, the access is, apparently our lawyers say we can't say like lifetime because of some like, I don't know, act of God happens or something, but like there's no time limit. There's basically forever. And I also forgot to mention, as you can see, this field gets updated. We have new research coming out, like the stuff I shared from just 3 weeks ago. So I record updates when there's new information. And so the course is continually updated as well. And that's free once you join.
Awesome. That's great. So all the updates you just continue to get. And if you look at the price point here, it's only $17.99 for all this. And again, the 20 CME credits. So you really can't go wrong with it. And I hope a lot of you take advantage of it. So any final thoughts, anything else you want to mention? Just make sure everybody, you download the ebook. So there's a link for that. That's absolutely free to all of you. And then if you want the course, do so by June 15th, because you'll get a bonus course on parasites, absolutely free, just thrown in for just our group. So I love that you're doing that too. Thank you. So any final thoughts you want to share with us?
Well, I guess I just want to say that I know that I would imagine that people are here listening because they don't find SIBO the easiest thing to treat, right? Or they're just new to it. And for anyone who finds it tricky, because it is, I just want to say, don't give up. It really is quite manageable once you have sort of like a set plan and you've got the treatments. It becomes so much less difficult. And I think it's one of the most rewarding things because it is a difficult field. And then when we're empowered to help people, it's so rewarding, you know? So basically, it's just encouragement. Don't give up. We can do this. We can do it well.
Great. One final question. There was a question from my health coach that this is also available to my health coach group, but if they don't have medical license, they can still do this course, right? And it's still going to be understandable and digestible, and no pun intended, but also it'll be available to use the herbals and things like that. They'll still be very effective at being
It's
able
open to
this.
everyone. You don't need any kind of license. I encourage people to come. I hear all the time from patients that it's either their health coach or their nutritionist that help them more than their gastroenterologist.
Mm-hmm.
Sorry, gastroenterologist.
I know.
But so I very
Not
much
the ones in this group.
Right. You guys are amazing. But yeah, absolutely. We have so many over-the-counter options available. And just one little note on that, as I made mention to it, for those who can't prescribe certain things, we have lots of cut arounds. Like for instance, there are some labs that you can lactulose in the US. We use lactulose breath testing for SIBO. Lactulose is a prescription, but we have various labs we can order that without prescription. And the Trio Smart you can order without prescription, and so many over-the-counter treatment options. Mm-hmm. And lastly, if you find your patient isn't responding to those and you need a prescription, you can do, what a lot of people who practice telemedicine do, which is ask them to go to their prescriber and see if they can get that, right? Absolutely. And still work with you for the rest of it. So we have a lot of options for treatment without prescription license.
Okay, great. Well, thank you again. You're getting tons of love on the chat thread, and
we
really appreciate it. And if you all have any other questions, post them below. Maybe she can come into the medical group that I run and answer some questions too. But do the course. It's not very expensive, and I'm sure all your questions will get answered there. So, all right. Well, thank you so much, Dr. Siebecker. I really appreciate it.
Thank you so much, Jody. Thank you, everyone.
Take care, everybody. Bye-bye.